bị tổn thương thận, suy thận gấp và thậm chí là nhiều bệnh nhân đã phải lọc máu. Và để tiếp theo thì xin bài trình bày của bác sĩ nội trú Nguyễn Việt Khánh đến từ Bệnh viện Đa khoa Quốc tế Hải Phòng với một cái chủ đề về các phân tích về các cái hiểu hình của kháng thể cá nhân trên miễn dịch hình quang trong chẩn đoán bệnh lupus ban đầu hệ thống. Vâng, xin mời bác sĩ Nguyễn Việt Khánh.
Thank you, Professor Thuy. Good day, everyone. On behalf of Haiphong International General Hospital, I'd like to thank the VRA board for the opportunity to share our work. It's wonderful to see so many colleges and also the experts together here in Da Nang. And today, I will be discussing the clinical utility of immunofluorescent ANA pattern in diagnosing SLE and also the prognosis of SLE. As we know today, SLE diagnosis remains a challenge, and we aim to discuss how specific pattern recognition can refine our clinical approach about the lupus patient, and let's dive into detail. So basically, as we know, lupus is a chronic autoimmune disease that results in multi-organ damage. The disease is characterized by periods of onset and relative stability alternating with special disease activity, and we call this the flare. And lupus was first described in the Middle Age, but in the mid-20th centuries, we discovered the anti-nuclear antibody and autoimmune mechanism. So we significantly advanced our understanding of the disease and recently the development of the immunosuppressive and biologic therapies have markedly improved the prognosis of the patient with lupus. So today we will be discussing about the autoantibody lupus. So basically we need to remind, it is so important to remind the time and the phase of the lupus. So autoantibody may appear up to 6 years of the clinical diagnosis of lupus, with the number progressively increasing prior to diagnosis. During this period, the disease involved from immunological phase, abnormality to a subclinical phase, and also non-specific symptom, allowing substantial organ damage to accumulate before lupus is formally classified. Lupus does not begin at the diagnosis, it begin years early in a silent immunological phase. So autoantibody such as ANA may be detected. It's about 50% of the case of the patient with lupus to systemic reveal, and the time is about 5 years prior to diagnosis. So these findings indicate that autoantibody development can predict the future emergence of the systemic lupus. So although autoantibody may appear years earlier, their presence not always leads to clinical disease. So lupus developed through a complex process involving alteration to immune response. So influenced by genetic and environmental factor, this complexity creates challenge to clinician to patient monitoring, treatment adherence, and identifying deeper pathogenicity mechanism. Why ANA positivity is required as an entry creation in the 2019 EULA-ICR criteria for SLE, the immunofluorescent ANA pattern of ANA are not incorporated into the classification system. However, this pattern may carry the information about diagnostic and prognostic information, potentially as a bridge between the laboratory finding and clinical phenotype of the SLE. So back into the basic. What is NAIFA? NAIFA is a technique to detect autoantibody using HEP2 cells, one kind of liver cell, and a substrate. So HEP2 cells display different cell cycle state, including interphase and mitosis. The fluorescence from reflect the cellular structure targeted by the autoantibody. Therefore, understanding the relationship between a fluorescent pattern and the cellular structure present during the cell cycle have clinical and laboratory specially interpret ANA result more accurately and may provide clue to underlying autoantibody profile and association of immune disease, including lupus. So to standardized interpretation of the ANA pattern observed by F2Cell. The International Consensus of ANA pattern ICAR proposed a classification system that could categorize fluorescence into broadly divided into three main categories based on the intercellular localization of target antigens, include nuclear pattern, cytoplasmic pattern, and cytoplasmic pattern and mitotic pattern. Among these, nuclear pattern are the most frequently encountered and clinical relevance of the lupus, and especially the most common nuclear pattern include homogeneous pico centromere nuclear pattern. So different ANA pattern observed by F2Cell reflect the localization of specific intercellular antigens and therefore associated with distinct alternative body specificity. For example, AC1 nuclear homogeneous pattern is commonly associated with antibody against DNA, histone, and nucleosome, which are frequently seen in lupus. Another pattern will get alternative bodies such as anti-SM and anti-U1AMP with the spical pattern or mitochondria pattern antibody with cytoplasmic reticular pattern. Therefore, an IFA pattern can provide important clue to predicting the underlying alternative body profile and guiding further serological testing. Moving on to a very important clinical correlation. This chart, referent from a study published in APTI 2022, illustrates the relationship between the complexity of RNA pattern and disease activity. And you can see the trend is quite clear. There's a positivity correlation here as the number of RNA pattern increased from the 1 to 4. We observed a significant rise of median SLEDAI score. This lists a key clinical takeaway. More pattern often equate to higher SLEDAI score. In practice, this means that identifying multiple coexisting in a pattern is not just a laboratory finding, it serves as a potential indicator of greater disease severity and more active systemic lupus. In 2022, a study published in Frontier, which aligned closely in our clinical observation regarding the prevalence of the ANA pattern. The spical pattern was the most frequently observed, accounting for over half the case, and followed by homogeneous pattern at 35%. A crucial finding here related to ANA pattern. The highest titer were found in patients with a mixed pattern, followed by those with spical pattern. This suggests that the complexity of the antibody profile often reflects a more robust immune response. However, the most striking clinical takeaway from this data is the pathogenicity of the peripheral pattern. Although it may be not be the most common, the peripheral pattern exhibits the most aggressive immune profile. So this is characterized by the highest level of anti-DNA, the lowest level of C4 complement, and the highest level of anti-phospholipid antibody. So when we do the research in our hospital, we understand there are many research gaps in the IFA application of lupus. The first one is the diagnostic value of ANA pattern according to the ICAP classification is remain underutilized. And we do not have evaluate the clinical significance of individual ANA pattern in relation to diagnosis, associated autoantibody, clinical manifestation, and we also do not have the predictive model based on ANA pattern, clinical feature, and also immunological marker to improve diagnostic accuracy and assist in the disease stratification and prognosis. So now I would like to share our finding from our own clinical experiment in Haifa. We conduct a phase 1 because we understand we are newbie on this space, so a lot of steps to do in the next time. Our study conducted to our 2025 involved a total over 200 patients. We focused on the cohort of 70 patients with ANA-IFA testing at the baseline, and after 6-month period follow-up, 15 patients were intimately diagnosed with lupus. It also entitled greater than 18. Looking at the distribution of a pattern in the first table on the left, the AC4 pattern was the most prevalent, accounting for 50% of the case. AC1 followed at 30%. We also observed mixed pattern AC1 and AC4 in 50% of the case. The most significant finding is shown that on the second table on the right, where we correlate this pattern with lupus nephritis because we understand the renal involvement because 30 to 40% of the patient with lupus develop kidney damage. It's about 5 years of onset, making it's the most common and severe early organ manifestation. Notably, 4 out of 5 patients with the AC1 pattern develop renal involvement, and furthermore, the patient with the mixed pattern present and diagnosis of the lupus nephritis. So the clinical data reinforce that why AC4 is common. The presence of AC1 and especially mixed pattern are strong indicator of renal complication in our patient population. So now, looking at the VRA case, I want to analyze the correlation between the ANA pattern and the severity of lupus nephritis. While CAS 1 and CAS 2 are mainly show AC1 or AC4, the clinical picture become much more aggressive in later stage. Notably, class 3 or class 4 is a proliferate form. We identify a mixed pattern. Most critically, the class 6 case representing the RPGU and rapidly progressive glomerulonephritis, also a mixed pattern. This together a vital clinical trend here. Mixed ANA pattern are strongly associated with proliferative lesion and rapid profile kidney renal profile decline. In our experience, a mixed pattern should immediately raise in a reflux severe kidney involvement. Despite its clinical value, we must acknowledge that implementing ANA IFA in routine practice comes with several significant challenges. We categorize to technical or and clinical aspect. On the technical side, we face 4 main hurdles. First, operator dependent accuracy of the result rely heavily on the skill of the technician, and luckily we have a talent for this. Also, there is still a lack of the universal protocol across different laboratories and time-consuming procedure requiring meticulous work under microscope. Moving to the clinical challenge, we often see limited clinical interpretation, also notably under use of ANA pattern. Physicians sometimes only look at the positive or negative result rather than the specific pattern where we discard. And lastly, the role in monitoring is remain a challenge to determine how often we should repeat the test to monitor disease progression or treatment response. Addressing the challenge is essential if you want to fully leverage the potential of ANA pattern analysis in improving patient outcome. So we have a few messages here. ANA fluorescent pattern provide additional diagnostic information beyond ANA positivity and titer, and standardized interpretation by ICAP and systemic analysis of ANA pattern maintain their clinical value, and integrating ANA pattern with clinical feature and immunological marker could improve diagnostic model of lupus. So in my final word, I would like to express my gratitude to Haiphong International General Hospital for supporting this study, my colleagues and collaborators for their valuable contribution, and also all the participating patients for their cooperation for in this study. And also thank you everyone for your attention.
Để trình bày một cái nghiên cứu có từ sau là